So welcome again. Thank you so much for being with us. This is Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. And today with us, we have Chelsea and Kenzie. And I should say, Chelsea Reichert Pasca is really Dr. Reichert, because she's a postdoctoral research fellow. And Kenzie is going the same pathway, and he's already looking for his PhD. He's joined the PhD program at Fairclough Graduate School of Yeshiva University. They're both from the Nathan Klein Institute, and they are in Orangeburg here in Rockland, but they are also in New York City with NYU, and I'm sure that you can tell us more about that yourselves. So why don't we start there? If you want to just tell us a little bit about the work that you do at the Nathan Klein Institute.
Thank you so much for the wonderful introduction, Sandra. And I'll share my slides in a little bit so everyone can see what all of our affiliations are. So we are part of the Geriatric Psychiatry Division, which is under the direction of Dr. Nunzio Pomara. This division's been around for about 30 or 40 years with a focus on memory and cognition in aging, especially with emphasis on understanding both risk factors and better ways to early diagnose Alzheimer's disease and possibly related dementias. We also focus on studying late life depression and its relationship to Alzheimer's disease, which we're going to mention a bit when we get into our presentation. And Kenzie and I have been working together on our community program, which is called the Memory Education and Research Initiative, which is a wonderful program that is available to Rockland County residents at no cost. And we will hopefully have some time to talk a little bit about it. Very briefly, though, it's something that any individual, let's say age 50 and older, can come to participate and get a baseline in terms of their memory and cognition. And so that as they start to age and get older and experiencing more medical conditions, we're able to test for and hopefully early diagnose Alzheimer's disease and related disorders. So I think it's a really wonderful program. I'll certainly have some more information to share on that.
And Chelsea, I believe you work with the Alzheimer's Association as well.
So we partner with the Alzheimer's Association very often doing community-based education. And more recently, we've actually been providing free memory screenings in combination with their education events so that an individual that doesn't want to necessarily invest time in, say, our MERI program, which is a long evaluation, takes about 3 to 4 hours, we can offer brief memory screenings, 15 to 20 minutes. They're maybe a little less intimidating and might indicate to an individual, right now I'm okay, I don't have anything to worry about, and I can kind of push that thing off. That might be giving me a little bit of anxiety or uncertainty in terms of my memory.
Yeah, and to our attendees, if you want to learn more about these, how you call it, assessments or screenings?
Both. We do memory assessments or memory screenings. We use them interchangeably.
So if you want to learn more about these assessments or screenings, you can actually go to community chats, because last year we had people from the Nathan Klein Institute coming and explaining what that looks like. And, you can find also information on how to get an appointment, because I understand those sessions could be like 2 to 4 hours or something, right?
Usually the first one is at least 4 hours, give or take.
Exactly. So now we know, just by the time that you guys spent on it, that this is very comprehensive. These people are serious about what they're doing. It's not, just a visit or anything. They are really dipping into what's causing Alzheimer's and depression. And that's why we have them here today. So I don't want to be doing all the talking. Please go ahead if you want to share your screen.
Yes, let me go ahead and do that. And something that's really wonderful about our program, and it's going to relate to a lot of what we're talking about, is that we are not, let me switch. You can see my slides okay?
Yes.
So with the Memory Education and Research Program, since it is a community-based program, it is also research-based, which enables us to carry out these extensive evaluations at no cost to our residents. And so we don't ask for things like insurance information. And so we actually are also not restricted by insurance companies and the things that might apply when you go to, your general physician or another doctor. So it's really wonderful because we are able to delve into what is going on, if anything. And one of the things that we do as part of our evaluation is assess for all of the different factors that could be putting somebody at risk for Alzheimer's disease, but including other health conditions. We're going to ask about things like COVID. So we are going to talk a little bit about COVID today and its relationship to Alzheimer's disease, what have you. So it's a really wonderful opportunity, and we want to put this out there for anyone in the community that might have concerns or just wants to get a baseline. So without further ado, let me go ahead and get started. And of course, we welcome questions throughout. As we were preparing this presentation and thinking about COVID, this kind of transformed a little bit in terms of what the focus is going to be. And we're definitely going to be talking about something called modifiable risk factors in relationship to Alzheimer's disease and also to dementia. So you can see here on the screen our primary affiliations, as we said, is Nathan Klein Institute in Orangeburg, New York. Throughout the presentation, what we did is we put questions up on the screen to really help the attendees think about, is this a question that I know? Is this something that I've been curious about? And Kenzie and I are going to go back and forth and kind of have a conversation about each of these questions. And like I said, we welcome any additional questions or clarifications. So whenever we do education events with the Alzheimer's Association or on our own, the very first question that we like to ask, or we like people to think about, is, what is the difference between dementia and Alzheimer's disease? These two terms are used often interchangeably, and sometimes that is incorrect in a sense. And so this wonderful graphic from the Alzheimer's Association really helps to kind of clarify what the difference is between dementia and Alzheimer's disease. And dementia really refers to an umbrella term. It describes a set of symptoms that are often associated with cognitive impairment. So for example, difficulty with memory, forgetfulness, trouble with thinking. And so something like Alzheimer's disease actually describes the cause of dementia. And so Alzheimer's disease in particular is the most commonly diagnosed type of dementia in individuals 65 and older. So very often when we think about Alzheimer's disease, or often when you're talking about dementia, we're actually referring to this, and we're referring to what is called late onset dementia. So again, anything that happens after the age of 65. That doesn't mean that dementia and including Alzheimer's disease cannot be diagnosed earlier on. So any individual who has a set of symptoms and an underlying cause of Alzheimer's before the age of 65 is actually considered young onset dementia. Some of the other causes that you've probably heard are going to be vascular, Lewy bodies, and frontotemporal dementia. These have possibly similar or overlapping symptoms with Alzheimer's disease, but again, different causes. Frontotemporal dementia is actually the most common type of dementia in individuals 45 to 65. And there's often a lot of overlap between these dementias. So most often an individual is actually going to present with a mixed dementia. They're not going to be purely Alzheimer's disease or purely vascular. And I think that's probably going to be the most scientific of terms that we're going to use today. We're going to try to keep this very light in a sense, but still informative. And just, unfortunately, this graphic didn't come out too well, but sometimes I feel like when I talk to my mom or some of the people that we test with in our Mary program, we often feel that people think they have dementia or think they have Alzheimer's disease because of the symptoms that they're experiencing. And so one thing that we're often asked is, what is the difference between normal aging or things we expect to happen as we age and something like Alzheimer's disease or related dementia? So if you look on the left side of the screen, normal aging, you might, walk into a room and forget why you went in there. I personally do this all the time. I misplace my cell phone all the time. Occasionally you miss a monthly payment. Occasionally you might be in a conversation and you can't think of that word. It's on the tip of your tongue, right? and then eventually it comes to you. So there are things that are considered normal. And a lot of times we can explain this in terms of the fact that we're busy. We're not always paying attention to what we're doing. We have too many things that we're juggling, especially if we're working or maybe caring for an individual. And so this can happen. When it becomes problematic is when you start to have problems all of the time. You can't take care of your monthly bills. You are starting to have difficulty remembering the day, the date, the days of the week. You can't have a conversation with an individual, or you can't understand what components of the conversation. So this is some example of the differences between what is normal, let's say, as we age, and what is more problematic and maybe requires some additional attention. And so just to kind of drive those points home a little bit, I'm going to actually turn it over to Kenzie so he can just continue on with the 10 warning signs of Alzheimer's disease.
Yes, thank you. So yes, as Chelsea was sharing, there are uh, a lot of concerns I think many people would have in when they notice certain memory issues that they might have. They get really worried that like, oh, this is Alzheimer's disease, or there might be something very serious. But when we think of Alzheimer's disease and other dementias, they're not like you wake up one morning and then bam, you have it, but it's a really gradual, the symptoms come on over time. And so there are some warning signs that, again, like Chelsea was saying, these aren't, it's not like a yes or no, you have it or you don't, but there's this difference in how strong or how frequently you have these issues. That's where the warning sign, that's where the concern might come in a little bit stronger. And so some of these warning signs that might come on early in the stages of Alzheimer's disease, the most pressing one would be the memory loss that disrupts your daily life, forgetting things all the time, or not being able to remember conversations you had even like a day ago, week ago, things like that. Challenges in planning and problem solving. This can be really noticeable in areas like finances in people's daily lives, where they start making really questionable financial decisions, or the way that they go about things might not be how they normally did them in the past. Difficulty completing familiar tasks, confusion with time or place as well. Even sometimes like we might forget, like, oh, I don't remember if today is the 11th or the 10th. But then there can be stronger signs of that where the confusion goes to even, I don't know what year it is, or I'm not sure like where I am right now, like what building is this? How did I get here? Confusion like that is much more, a little bit more of a concern than the forgetting like what day of the week it is, because sometimes we just all forget that. Trouble understanding visual images and spatial relationships. This one's interesting because it's not as commonly understood as a sign of Alzheimer's disease. But actually, many people with the illness do have difficulties making sense of what it is that they're looking at, which in real world settings, the most pressing time this comes up would be when you're driving. It can be really difficult to even tell like how close or how far you are from certain things, and that can cause a lot of difficulties when driving, and possibly lead to accidents. Even being able to tell like what shape certain things are. There are things that you don't necessarily think about all the time, but it's a gradual. It gradually comes on more, and then um, yes, it can lead to those kind of difficulties. So that is a warning sign to look out for.
Can
Um,
say, on this sounds very interesting to me because wouldn't this be
mhm,
something that could be easily confused with just like vision problems or eye
mhm.
problems and be like, oh, you need glasses and problem solved?
Exactly. So that is a great point. Thank you for bringing that up. That is something that we would also, in a diagnosis or in like an assessment for Alzheimer's disease, we would want to make sure like, well, you're having some visual issues. Is there a chance that it might be due to some other visual impairment specifically? Or maybe you just like need a better prescription for your glasses? But we would try to sort of parse that apart, see like, is it because of something else, or is it maybe combined with all these other things, and then maybe it's actually a symptom of Alzheimer's disease. So there are things like that where it is hard. All of these warning signs put together sort of make that image. And of course, some people may have some symptoms and not other ones as well. So that's where the trained neurologists or trained doctors are needed to put all that together and understand the bigger picture. But yes, thank you for bringing that up. Um, and yes, so then beyond that, there's also problems with words, finding the right words to say or things like that, misplacing things and losing the ability to retrace your steps. This connects a lot to the memory loss issues, but more in a practical sense. Decreased or poor judgment as well. Again, thinking about how you're making certain financial decisions or life decisions. Withdrawal from work and social activities. This is one as well that we will talk about more extensively later on, but we notice that people become a little bit more socially isolated. They don't really want to engage with other people as much or go out into social settings because it can be difficult and these symptoms are much more present. And people might notice like, oh, you're acting a little different, and they don't really, you might not want to like be like present around that, so you would rather just withdraw away. And lastly, there are also changes in mood and personality, higher rates of depression and anxiety as well. There are mood changes that occur separate from these cognitive issues we've been talking about so far. And so these are some of the warning signs of it. And we do have certain assessments to test for them. The ones that have stars next to them, those are ones that we are able to test in when you do come in for a neuropsychological assessment. We can test things with memory, we can test your vision, time and place. Some things we do have to just ask either you or a loved one, someone who knows you a little bit better. Things with like the difficulty completing familiar tasks. We can't necessarily have you doing familiar tasks in a setting when you come in for testing. So that we would have to ask and see like, is that something that's been coming up more? And that comes as part of a longer interview that a doctor would have with you.
And Kelsey, when you say new problems with words in a speaking or writing, I'm also thinking about people like me, that English is their second language.
Yes.
So how do you assess that? Because sometimes I'm looking for a word and I can't find it. And it's not that I have Alzheimer's, it's an ESL issue. So how
Yes.
do you differentiate that?
That is a fantastic point, and especially something that's really present for us in living in this area where it is a very diverse population. We have many people who are learning English or learned it like early in life, so it's more common for them, but there are still going to be some language difficulties there. And that's something that, again, like we would want to pay close attention to. That's why it's good to have a full background understanding of a person's life, knowing did you learn English as your first language or is it something you learn later? That would probably play a big role in certain language issues. Ideally, we would get tested in the language that we are most comfortable with, but for some people that might not always be possible. And so that's something that we would have to take into account and yes, sort of see how we want to consider the symptom severity of that.
And how many of these do you need to show in order to have positive diagnosis?
Yes, so that's also something we will talk about later as well in terms of diagnosing Alzheimer's. But there is a lot that goes into it. There's not really one specific, like once you have this, this, and this, that's Alzheimer's. It is a whole picture that a trained doctor would have to be able to see and put together alongside medical history, things with neuroimaging like PET scans or CT scans as well. We would have to put all of that together to see a bigger picture of whether something is Alzheimer's or it may be something else.
And to piggyback off that, I know we're going to get into this, but if you go to a doctor and they do one test and you don't perform well on that test and they say you have Alzheimer's disease or you have dementia, in these particular cases, that is not going to be, that's not ideal. So you should be having a much more thorough evaluation and seeing lots of different doctors in a sense, you know, an expert who's going to be able to do neuropsychological testing and confirm how are you performing on these tests for your age and your education level. And not just looking at how you perform on those tests, but taking into consideration things like what is your primary language? You know, we do several tests that look at language or word production, and they are English-based tests, and we are administering them in English. So if an individual has is their primary language is not English, they may not perform as well on that test. So we can't necessarily take that as face value, at face value, excuse me. So these are really important things. And when we do our case reviews of people that come in for our Mary program, this is the type of stuff that we're talking about. So these are really wonderful questions that you're following up with. So related to Alzheimer's disease and dementia, so now we know what symptoms to look out for, even though we don't necessarily have to have all of them or some combination of them. Are there known risk factors for Alzheimer's disease or for dementia? And so in terms of Alzheimer's disease, I'm going to turn it back over to Kenzie, but I did want to just mention quickly that there really are two types of Alzheimer's disease that we are talking about here. There's something called familial Alzheimer's disease, which occurs in about 1% of people. And in familial Alzheimer's disease, you have a mutation in a known gene. There are 3 particular genes that can be have a mutation that lead to this disease. Typically, the symptom development is much earlier, and you have the mutation, you get the disorder. But the majority of cases that we're talking about, the majority of Alzheimer's disease is actually what we call sporadic Alzheimer's disease. And so really what it's going to be is a combination of both possible genetic risk factors, other risk factors, and also our environment, of course, the interaction of all these things together. And so that's what we're really going to be focusing on for the majority of the rest of the presentation.
And Chelsea, you're talking about a genetic mutation. So once that genetic mutation happens, then your family is at risk or your descendants, or it's just for the individual?
So it's for,
I guess it's hereditary. That's what I want to ask, you know, the genetic mutation.
So in that particular case, it's going to be the individual. If they have that particular genetic mutation, they are going to develop Alzheimer's disease, and the symptoms are going to occur much earlier, let's say in the 40s and probably in the 50s. Very rare for this particular type. Like I said, only about, I looked on the Alzheimer's Association last night to confirm it's about 1% of individuals. That might put your family at higher risk, but they would have to have that same mutation. But the majority of what we're talking about is this is not the case. So let me, since this would more apply to the major public, I'm going to turn it over to Kenzie for this.
Yes. And yeah, so there are these 2 like categories, I guess we would consider with Alzheimer's disease of sporadic and then familial. And for sporadic, one of the greatest risk factors is just getting older, old age. The chances of developing Alzheimer's disease in these certain decades do increase. So from between like 65 to 74 years old, the chance is 5%. From 75 to 84 years old, the chance does go up again to 13%. And then once you're looking above 85 years old and above, the chances get around 33%, so roughly 1 in 3. So age is a very large risk factor for that, that we can't necessarily control, but it's something that we can just be on the lookout for. But in terms of things that are more with the family risks, there is family history that we would look at in making a diagnosis as well to see people are more likely to have Alzheimer's disease if certain family members do as well. And as Chelsea mentioned, there are 3 main genes that we do consider. The one that's the most pressing, or the one that tends to get the most attention, is something called apolipoprotein E. We just call it ApoE. And there's 3 types of it. There's E2, E3, and E4. Most people in the world have E3, and that really hasn't been seen to have any kind of impact on developing Alzheimer's disease. E2 has been seen to actually have a lower chance of developing Alzheimer's disease compared to the average person. But then having E4 would make you more likely to develop Alzheimer's disease. It doesn't mean that you will develop it absolutely, but the chance of developing it does go up depending on having E4, or in some people's situations, they may have two copies of it, one from their mom and one from their dad, and that would increase your chances much more. And so there are genetic tests people can take as well to see whether that is something that they may want to be on the lookout for. But again, just because you have a certain gene doesn't mean that you will develop Alzheimer's for sure. So that is something that we do want to stress and not cause excessive worry or this feeling of like just surrendering to there's nothing I can really do about it, so I might as well just accept it. There are things that we can do considering other risk factors as well, which we'll talk about more.
And I actually just want to add to that before we get to the next slide that the Alzheimer's Association actually somewhat discourages, I would say, getting a genetic test to know what your genotype is in terms of this E4 gene without also consulting with a genetic counselor. So if you're going to learn some type of information, you want to make sure that you are also consulting with an expert in this field so that you better understand what exactly your risk is. So this E4 gene is a risk gene, like Kensei said. If you have this gene or certain combinations of this gene, you don't necessarily get Alzheimer's disease, which is different than the other three genes, the names of which I did not provide, and that's for that familial Alzheimer's disease. So that's a different category. Okay, and so before we dive into the different modifiable risk factors, the other category on the last slide, I just wanted to make sure that everyone who's here today, if you're not familiar with Alzheimer's disease, I just wanted to briefly mention what the hallmark signatures are of Alzheimer's disease, or what we know in the field as of right now. So something that you've probably heard about is amyloid beta, which is fragments of protein that tend to build up in between the neurons or nerve cells in the brain. And what researchers believe it does, it actually reduces the ability of neurons to communicate, which is really important in our brain. In order for things like memory and thinking and cognition to occur, we need to have neurons or pools of neurons communicating with each other. It may also contribute to an inability of resources to get to those neurons. So all of the cells in our body need energy to function. They function like little factories. And when you stop the ability of these nutrients to get to those neurons, the factories can't work. And so as the disease progresses, what we also start to see is things happening inside the neuron. So another term you might hear is tau. So some of the important proteins within the neurons start to tangle up and cause the cell to not be able to function properly, that factory to stop working, and basically to have the neuron start to die. And that also leads to additional difficulty with these cells communicating with each other. Really, really problematic. This can start to begin way before Alzheimer's disease, as many as 20 years before any symptoms start to appear or any diagnosis is made. And it starts in the areas associated with memory and thinking. And as the disease progresses and as the symptoms start to appear, we see these changes, whether it's the formation of the beta amyloid plaques or the dead and dying nerve cells start to appear and spread throughout the brain, and kind of corresponds with the amount of severity of symptoms. One thing I want to point out, because I don't want anyone to be too concerned, our brain and our body has the ability to deal with the formation of these plaques. We do have cells in our brain called glial cells. That's the more general term. And they do have the ability to get rid of these beta amyloid plaques and deal with dead and dying neurons. That is how the brain functions. And so this is very important. But what researchers have found is that in Alzheimer's disease in particular, and even in related dementia disorders, it's like the glial cells at a certain point can't keep up. And so the production of these plaques kind of overwhelms this body's innate ability to deal with it. And so this is a very active area of research. So in setting the stage, we probably already answered this question or talked about that there are risk factors that can be modified. And so this is really important because while you can't change your genes, And sometimes we're not even able to change our environment. There are different risk factors that we talk about that if you are able to modify them or deal with those factors before they become a problem, you can actually reduce your overall risk of developing, let's say, Alzheimer's disease or a dementia. And this is actually going to apply to a lot of different medical conditions. You know, things can lead to worse outcomes if you don't deal with them. So I'm going to turn it back over to Kenzie to talk about a particular figure that is related to modifiable risk factors.
Yes. So yes, there are certain risk factors that we are able to change. Of course, this is an ongoing field of research. Every day we're discovering something new about just how some of these risk factors are connected to Alzheimer's disease, or even the fact that there are certain risk factors, we're discovering new ones. So this is all a very active area that we can spend uh, hours and hours talking about every single one of these. So we'll try to just go over it briefly. So in general, one of the earliest risk factors that we have seen makes a difference in whether someone develops Alzheimer's disease or not is your education level. We've seen that people with higher levels of education, going to college or anything beyond, do tend to have lower risk of Alzheimer's disease and dementia than people who don't receive higher levels of education. And so this is also one area that we would want to, as a society, try to help people overall to develop and get more education for many other reasons as well, but also in terms of lowering the chance of developing Alzheimer's disease. In midlife, hearing loss is a big one particularly. We've noticed that um, people who do have trouble hearing, uh, whether for the reason that they are not able to converse as well with people, and that can sort of lead to cognitively you're not really engaging as much with other people, and that may be the thing leading to the dementia, or something maybe a little bit more neurological happening there as well. Again, these are all active areas of research to see what exactly the connections are, but we've seen that if we can resolve that hearing loss, then there is a lower chance of developing that Alzheimer's disease. Traumatic brain injury as well. Hypertension is a really big one, especially in the United States. We see that many people have hypertension or high blood pressure, and that has been linked to a wide range of health complications. But we've seen that heart health and your cardiovascular and blood pressure does actually play a really close and big role in your brain health, in the amount of oxygen that your brain is able to receive and function well. Um, there's been a lot of connection seeing that rates are higher, having hypertension has a higher chance of these cognitive difficulties. Um, and so in a diagnosis, we would want to see if there are certain like treatments that people can take for hypertension to reduce those chances or reduce some of those cognitive deficits people might be experiencing. But then, as we'll talk about later as well, medications have also been seen to have certain interactions with dementia that we will want to consider as well, that you would want to speak with your doctor about. Alcohol and smoking have also been tied to increased chances of developing Alzheimer's disease. And so that is something that we would try to encourage people to cut down on or reduce as much as they can. Um, Obesity is, again, similar with hypertension, something that affects a wide range of health issues. But with Alzheimer's disease and with dementia, we've seen that, or research has shown that obesity, especially with the increased amount of certain leptin protein in your body, has been connected to developing or affecting the amyloid plaques that Chelsea mentioned before. So that's something that we would want to try to control as well, or something that people can uh, lower, reduce obesity to reduce the chances of Alzheimer's disease. And something that in our lab that we study and focus on a lot more is with depression and social isolation. that has also been seen that um, depression does, can, of course, in older age become more common, and is something that we, again, will talk about later as well. But depression has been seen to affect, especially in older age, affect more cognitive functioning, noticing more memory difficulties, and also that social withdrawal that where people might not even notice that there are some difficulties, challenges people are facing, and that can prevent or delay the diagnosis of Alzheimer's disease as well. Physical
Yes, I
activity.
see. Sorry to
Yes.
interrupt.
Oh,
So
it's
I
okay.
see that depression is scoring high here, and I'm wondering, maybe there are some people with depression that also prefer to forget certain things that happen in their lives. So how would
Mhm,
you differentiate, like true Alzheimer's
mhm.
from, selective, how do you call it, forgetfulness? I don't know.
Yes, so that is an interesting question. I think that would be something that we would want to consult people individually with, and when talking with them, try to see like how exactly the depression is affecting their life. As you said, some people may just not want to, because they are depressed, because their mood is so low, they may not want to cognitively engage so much with the world. But that's something that we would want to hopefully try to address. And of course, for the reducing the chances of dementia, but also just for your own mental well-being and your own health, want to provide therapy or whatever medications or treatments to lower that feeling of depression, and hopefully to improve your overall well-being along with that. Yes.
To add to that, and I know we're running kind of low on time. It's a
Mhm,
great question though, and to add to that, it very much has to do with how we test for impairments. So, it could be that an individual is wanting to forget things or experiencing forgetfulness because they want to. But when we do formal testing, especially in the areas of like verbal memory or even in visual memory, then we might not see deficits on the testing, which is really going to be important. However, and since I'm not sure that we'll have time to get to the slides on depression, that something we often see and something that we saw as a result of the pandemic with an increased experience of depression and depressive symptoms is sometimes people feel that they're having impairments in memory, but it's actually depressive symptoms. And what we find is that very often is that individuals coming to our memory program, our MERI program, aren't aware about what the depressive symptoms are, that depression is not just sadness. So that's a really important thing. So it's not a straightforward answer, but we can test for it, certainly. Especially we can test for depression, and seeing a psychiatrist is really important for that, or a psychologist. So I know since we're running low on time, Kenzie, I want
mhm.
to keep going if that's okay.
Yes. I'm wondering if we should move on ahead just and get to the COVID sections.
Yep. So something I want to point out, so all of these different risk factors, these percents essentially scientists have figured out, if you control for smoking or reduce your depression or address the fact that you're socially isolated, you're going to reduce your risk overall for dementia. And this is really important because I found a statistic that 83% of people that actually have subjective complaints about their memory or cognition also have at least one other chronic medical condition. And so that's really important because if you address those chronic medical conditions, you might reduce your overall risk for developing dementia eventually. But the field is still developing because a lot of these studies are just comparisons of people who smoke and people who do not smoke, or people who have hypertension and people who do not have hypertension. So our understanding of the relationship between these risk factors and then developing dementia or Alzheimer's disease is complicated. We can't necessarily determine a cause and effect without doing what's called a randomized controlled clinical trial, where we're assigning people to groups and we're controlling for hypertension, or we're controlling for this factor and that factor. But the field is certainly moving that way. And there's lots of studies going on in terms of physical activity, so exercise, sleep, also in terms of hypertension. So controlling for hypertension within a healthy range leads to reduced dementia and reduced cognitive decline. Sleep is really important. I forget if sleep was on that factor, but there's several different studies that have come out as of late. There was one this week. There was another one on the news. Basically, the takeaway message is if you don't get enough sleep, you're more likely to have increased amyloid beta plaques in the brain. If you have sleep apnea, you might be at increased risk for developing dementia or Alzheimer's disease. And so it's really important to make sure we're getting enough sleep, and not just enough sleep, but uninterrupted sleep. And so one of the studies that came out was actually finding that people that have reduced sleep early on in life, in their 30s and 40s, may lead to greater cognitive decline in 10, 20 years, which is, you know, for someone like myself who has an infant, this is really disturbing, so to speak. There was another study that came out this week, or that was published this week, where they found that people that have reduced sleep, so under 6 hours, so the ideal amount of sleep for an adult is 7 to 8 hours, as difficult as it may be to get, but people that have less than 6 hours of sleep, it counteracted the benefits that physical activity has, the protective factors. So that's really problematic. And since so Sandra, do you want us to leave some time for questions? We haven't gotten through half of our slides, but do you want us to leave time for questions or keep going?
I'll keep going. And, you know, what I'm going to do is I'm going to invite our attendees. If you have any questions, to start writing them down. But yeah, okay. This is very interesting. So keep going.
Okay. So Kensei, I think I already mentioned this about hypertension, and Kensei's already been talking about hypertension, but there actually has been a controlled trial showing controlling for this reduces chance of cardiovascular events, and that can reduce your chance of dementia, probably more likely vascular related dementia, but there is a lot of overlap. And I know Kensei also, diabetes was on the chart that he had earlier. I think the takeaway message here is that medical conditions like diabetes, which increases your risk of stroke and heart disease, if you take care of your diabetes, if you control your diabetes and work with your doctor, then you're going to reduce your overall risk. The link is unknown, but it seems like the overall theme here is if we're more healthy and we're more active and we're more engaged, and then we're going to reduce our risk overall, and we're going to live a long, healthy life. One thing to quickly point out, because I do want to get to some of the information on COVID, but there are some commonly prescribed medications for things like anxiety or pain. So Xanax, probably everyone has heard of. In our lab here at the Nathan Klein Institute, we have done several studies looking at giving individuals these commonly prescribed medications and looking to see what the impact is on memory. And so what we found is that the use of some of these medications resulted in cognitive impairment and memory, and that impairment lasted. And this is actually something that we often see in patients coming in, that maybe they report memory problems or confusion, and it very much can be related to the medications that they're taking. So I am not a medical doctor, as has been pointed out. So it's important, if maybe an individual is taking one of these medications, that they consult with their physician to see, you know, do I need this medication, or am I using it for too long of a period, especially if they're starting to experience some sort of deficit or notice a deficit and it's lasting. Definitely important to point out. Okay, so probably the one question that everyone has been interested in is, does COVID have an impact on Alzheimer's disease? And this is a big question. I think one thing that we've noticed in our own research is that not necessarily COVID, the disease, but COVID, the experience, the pandemic itself has had a very big impact on our population. We have found that individuals that we've been following for years had experienced increased rates of depression, increased rates of social isolation, and as a result felt that they were experiencing more changes in memory and cognition, which is really, really important, because these changes, both the depression and the social isolation, have continued. In terms of COVID itself, though, this is an active area of research, and you probably have seen advertisements on television. I think NYU is doing some research on this. I think UPenn is doing research on this. And so what we found is, or not us, we have not been researching this specifically, but other researchers have found that COVID may lead to cognitive impairment. And the most common thing that you might hear about or even experience yourself is brain fog. So this It could be forgetfulness, it could be difficulty paying attention, it could be concentration issues. And so that is really important. And that is something that seems to persist, not only after COVID resolves, after somebody, let's say, tests negative, but it can last for, let's say, days, months, or even weeks. I said that backwards, days, weeks, or months. Now, while COVID was going on, research was also actively going on. So there are several researchers in the field of Alzheimer's disease. NYU is one of the places that this happened. They were measuring the blood levels for certain biological variables in individuals that were in the hospital for COVID. And they found that individuals with COVID had increased biological variables that are associated both with brain inflammation and also with Alzheimer's disease. So although they don't know necessarily the link at this moment, the conclusions are that this may lead to lasting impairment, but we really need to study it. So people that are experiencing long COVID, it's really important that they are part of research and helping researchers to understand what exactly the link could be. Let's see, so Kenzie, I don't know, this is a really important point that we should definitely spend some time on. But if you don't mind, I'm going to just jump to the next one and then we'll come back.
Yeah.
Because a related slide is more about brain fog. And so I just wanted to point out that the research shows that 1 in 5 people who experience long COVID, so anything that persists after COVID has resolved, report experiencing this brain fog. And like I said, it can happen for weeks, months, actually even years. In our own research, we have actually not come across this too much, maybe 1 or 2 cases in the couple hundred people we see each year. And so people report, like I said, cognitive symptoms. So this could be memory problems, attention and concentration, even language issues, and it can disrupt your everyday functioning. In the few individuals that we have seen that have reported brain fog, it has actually not reflected on the testing that we do, which is interesting. And a lot of the research that I read on this actually reported the same thing, that impairments in memory and concentration are self-report. It's the individual saying, I'm experiencing this, even though it doesn't map onto the testing that's being done. And so an article just came out that is linking the COVID virus and its persistence to remain within the gut and possible disruption in things like sleep and memory. Which is very, very interesting. It's ongoing. It's a very exciting field since COVID seems to be sticking around. So I just wanted to point out that not only is there a link between COVID, cognitive impairment, and Alzheimer's disease, but that it's an ongoing field. And so it's ever evolving what we're learning about this. So
yeah. And I would just like to add on to that as well that a lot of the measures that we do use have been more designed for certain diseases as well. Like a lot of Alzheimer's assessments are specifically for the symptoms that we would notice in Alzheimer's disease. So using those might not necessarily capture the kinds of memory difficulties that people with COVID have or with long COVID are experiencing. So again, because it is still a relatively new area of research, research does take many, many years to really come to conclusive understandings. This is something that many people are still trying to understand how exactly long COVID does affect cognition. But yes, in terms of diagnosing Alzheimer's disease, as we've been talking about over and over again, the biggest and most important thing is to see a doctor. People who have been trained to parse out all of these things we've been talking about, not just, oh, you have memory issues, so we're going to say you have dementia and move on with our lives, but really wanting to dig into it through exams, testing with neuroimaging as well, all sorts of things that we try to put together, as well as interviews, talking with you and seeing how your day-to-day life is, talking with family members as well to see if there's things that you might not notice about yourself, but family members would recognize. And so there's really a lot that goes into it where the diagnosis, unfortunately, there's not one specific test we can take. It is a very whole, comprehensive process to come to that diagnosis.
I would say at a minimum, you should be seeing a general physician, and they should be looking at all those chronic medical conditions you have, making sure they're under control. You should also be seeing probably a neuropsychologist or somebody that can do an extensive test battery to look at the different areas impacted in cognition, in Alzheimer's disease or dementia. Interviews with family members, and some sort of imaging. So you should likely see a neurologist and get what we call a dementia workup. So you should have an MRI to rule out if you have any history of stroke, or other possible things that could be going on. And then now PET scans are becoming a bit more routine. And so we actually are able to image to see if you have these beta amyloid plaques, which is going to be a key component nowadays of a diagnosis of Alzheimer's disease in particular.
Mhm.
So I don't know, Sandra, do you want us to stop?
We have 2 minutes and we have no questions yet from our attendees. So if you want to use those 2 minutes to...
Sure.
Yeah.
So we already mentioned that the pandemic did lead to increased, at least in the people that we work with, increased rates of depression. But social isolation is really important. It's been on the news. The U.S. Surgeon General has raised this as I want to say an epidemic as well. And so as we get older, very often we lose family members and we have a tendency to become more socially isolated. And social isolation is more than just being physically isolated, because you can actually live with other individuals, but still experience the components of social isolation. So social isolation includes loneliness. And loneliness in particular is a problematic concept because this emerging area of research in the last 2 to 3 years, I would say, has found that individuals who report being lonely have increased rates of depression, and are also at greater risk for dementia. And like I said, in the last 2 to 3 years, there have been several studies on this that find that people who report being lonelier have more of these beta amyloid plaques that are associated with Alzheimer's disease. And so we are one of the groups that are now starting to try and understand what this connection is. And so one way to study this is to reduce social isolation. And so being more socially engaged, we have found, or others have found actually, that leads to lower levels of brain amyloid. And the problem with the current studies that have been done is that it's these comparison studies, people who report being engaged versus people who report being more withdrawn, and then they look at the different levels of these proteins in the brain. And what the field is moving forward, or what we hope the field will do moving forward, is actually more controlled studies where we engage people with certain activities, although I will end with the fact that there is no specific activity that's going to lead to reduced social isolation or reduced depression, reduced dementia. But what the research shows is that whatever you need to do to stay engaged, whatever brings you enjoyment, is what you should do. So if it's reading books, if it's crafting, if it's volunteering, if it's taking a class, that's what you should do. And that's how you're going to reduce your overall risk of depression, isolation, dementia, etc.
Mm-hmm. And Chelsea, just to end, we're going to end with a question from one of our attendees. Can you speak a little bit about the connection, if there is any, of Alzheimer's disease and Parkinson's?
So they are 2 different disorders with different causes. And so Parkinson's doesn't necessarily lead to dementia. So I want to say it's about 40% of people that have Parkinson's disease, which is more of a movement-based disorder. It is also a progressive neurodegenerative disorder that is known to be more sporadic in cause. So it's much more a combination of your genes and environment than a known genetic mutation. But I think it's something only like 40% of people that experience Parkinson's disease also experience dementia. But importantly, in Parkinson's disease in particular, there are high rates of depression. And so that could put an individual at greater risk for either dementia or an overlapping Alzheimer's disease.
And social isolation too.
And social isolation, exactly.
Mm-hmm. Okay, thank you so much. Well, this was amazing. Thank you so much for all this information. I'm definitely sending you an email because I'm bringing you back so that we can go into all those other slides that we had to skip today. Yeah. I know that it's very good information in there as well, but I'm very thankful that you did this for us today. And again, I can't wait to see you guys again. And thank you to our attendees. Next week, we're going to have ending the HIV epidemic. We're going to be talking about the past, present, and future of HIV. So join us again, community chats. You too, you're invited, Chelsea and Kensei.
Interesting.
So if you want to learn more about HIV next week, I will see you here in community chats. Have a good day. Thank you, everyone.
Thank you for having us.
Thank you for having us.